any crepitation to suggest any APO. CVS was unremarkable. Uterus felt tense, and we were unable to detect any fetal heart via deptone. But otherwise, there was no evidence of any active bleeding per vaginally, no evidence of incontinence anywhere to suggest any recent fitting episode. So, at this point in time, what do you think is the diagnosis? Placenta abruptio. Okay, good.
With any other differential? Right. Do you have any differential? Why not? Come on.
Sorry, Prof. I'm still. For now, just placenta rupture. Sorry, Prof.
Okay, they give up. Surrender.
Okay, but it was a good, good differential. That was also our provisional diagnosis at that point in time. So it was a silent clue as there was no obvious bleeding. However, we must always remember that abruptio can mask behind minimal vaginal bleeding. And the clues were possibly that uterus was tense with a disproportionate shock. What does that mean? It means that the amount of bleeding the patient present with. So with this being said, we started resuscitation from home. We inserted large bore cannula, ran patient, and we were able to bring up the SpO2 to 97% under high flow mask. And then we scooped the patient and bring her straight to hospital. So upon arrival to the hospital, the red alert was immediately activated, and this brought about an MDT response. We were able to bring in the casualty team, the ONG team, NS team, and also the pediatric team to be on standby upon our arrival. So while she was at red zone, blood investigations were taken. We set another large bore granula. We ran further fluids, and we were able to rate of 120. Otherwise, when we assessed the abdomen was now woody hard, and there was difficulty palpating fetal parts. Scan-wise, thankfully, we were able to get a fetal heart with a fetal heart rate of 130 beats per minute. So while we were preparing patient for delivery, suddenly we noted that the linen was fully soaked with fresh blood. And that was when we realized that patient now had active PV bleeding. So we then reviewed the blood investigations that were sent stat to the lab. We noted that the ABG showed severe metabolic acidosis with hypoxia, with a pH of 7.27, a bicarb of 14, and a PO2 of 69. The lactate was also high at 7.4. FBC showed mild anemia, 10.4, with mild thrombocytopenia at 146. However, when we look at the coagulation profile, it was severely deranged. The INR was up to 5.64, with an APTT of 116. We did think about possible liver dysfunction. However, liver function was otherwise normal, so it was unlikely the cause of the coagulopathy. Cardiac markers was also raised at 1012. We did rule out other cause of reduced consciousness. We did try to rule out DKA. The BSP stat was 12, however, serum ketone was 0.2, so it was unlikely DKA. So at this point in time, like what you said, yes, our initial diagnosis was abruptio placenta with coagulopathy. So we immediately started on blood transfusion, and we also activated a massive transfusion protocol. So what is the management for abruptio placenta?
Come on. Anybody would like to try give that answer? Mana year 4 and year 5? Kat tangan. Semua tak ngaku. Come on, where's the year 4 and year 5? Year 5 you definitely have done ONG kan? How come somebody wants to answer? Looks to me like it.
Emergency cesarean section. Resuscitate the mother.
Okay, acceptable. Okay. So yes, our management will usually be number one, stabilize the mother, and then number two, bring patient for delivery. So at this point in time, mothers comes first. So we started the transfusion immediately and stabilized the patient with the help of NS and also ED team and brought patient in for delivery in the operation theatre. So emergency cesarean section was done under GA. And upon intra-op finding, upon entering the uterine cavity, it was just frank blood. It was not blood stained like it was just pure frank blood. And we also faced difficulty as we noted there was persistent uterine atony. Despite aggressive measures with multiple uterotonic agents and also compressive sutures, we still had a massive hemorrhage up to 3 liters. So in terms of the baby, as anticipated with the massive blood loss with abruptio, baby was delivered pale, cyanosed, and limp. He was delivered with a poor APGAR of 1 in 1, 4 in 5, and 6 in 10. And the baby was acidotic with a cord blood pH of 7.05. The baby required PPV and also intubation, and subsequently was transferred to NICU. Okay, the mother was then transferred to ICU, and this is where the plot twist occur. So all this while, we think that it was abruptio. So we did what we could for abruptio. We stabilized the patient, we delivered the baby. However, despite all the resuscitation, despite the aggressive transfusion and crystalloids, mother was still unstable. We were unable to stabilize the blood pressure, and the mother required inotropic support. The mother was also persistent tachycardic, and they had difficulty maintaining ventilation. So something was not right. And thankfully, with the NS help, NS did a bedside echo, and they managed to detect a right heart strain with a McConnell sign positive. This will be further explained in detail by our NS specialist. So with the right heart strain and the McConnell sign, it was suggestive of pulmonary embolism, and thus we proceeded with CTPA. So lo and behold, the CTPA showed massive saddle pulmonary embolism with extensive bilateral thrombus and with the right ventricular strain as has been seen on the echocardiogram earlier. So at this point in time, what is our management for pulmonary embolism? Or what is a common management for pulmonary embolism?
Okay. Yang ni kena tanya level up sikit. Come on, registrar.
As this is a unstable, hemodynamically unstable pulmonary embolism, so option is we can do some intervention radiologies for thrombectomy of the blood clot, and also other than that we can use medication, thrombolytic therapy for the thrombosis.
Thank you.
Okay, so thank you, Dr. Fazli. So commonly for stable pulmonary embolism, management will be with antithrombolytic agents like subcutaneous. However, in this patient, as she has severe coagulopathy, so the management with subcutaneous is not suitable. So at this point in time, we were thinking whether our diagnosis of abruptio placenta, was it an initial presentation or was it a sequelae of the pulmonary embolism? So we then postulated a possible hypothesis that probably patient had pulmonary embolism to begin with, leading to severe hypoxia, which brought about full-blown DIVC and subsequently bringing about the abruptio placenta that she presented with. This could actually explain why the coag profile was severely deranged despite having a HB that was holding on at 10.4 upon arrival to casualty. So the case was then immediately discussed between multidisciplines. We brought in, NS team was there for stabilization, and we referred to interventional radiology team, which provided the intervention of embolectomy. That will be further discussed by radio team. So updating on the progress of the mother was subsequently nursed in ICU until day 3 post-delivery and embolectomy, and mother was then transferred out to HDU as she was stable. She was subsequently discharged home well on day 10. In terms of the baby, as we saw that baby was acidotic initially, baby was then treated for perinatal asphyxia with severe HIE. Baby was started on cooling therapy until day 4 of life. MRI brain was then done on day 5 of life, and thankfully, the MRI brain showed no evidence of HIE. Baby was then discharged well on day 11 of life. So before I end my talk, I would just like to remind everyone that every maternal collapse is a race against time. Every minute lost, you can either lose the mother's life, the baby's life, or we could lose both. With that, I thank you.
Thank you, Dr. Pei. And I would like to call upon the second speaker, Dr. Rowaidah from the Department of Obstetrik and Gynecology. Oh, sorry. Call upon the second speaker from Department of Anesthesiology.
Assalamualaikum and a very good morning. Assalamualaikum and very good morning to Prof. Datuk Dr. Marina, our Dean of Faculty of Medicine, and Prof. Nur Azlina, our Timbalan Dean, and Head of Department, my Head of Department, Prof. Mohammad, and ONG Department, Prof. Ixora, and lecturers, and my fellow students. So when I was preparing this slide, I was decided to put an echocardiogram as my first slide. Now I realized that I'm actually not a radiologist, nor am I a sonographer, and my head of department is here, so I put a laryngoscope on the top right-hand corner to compensate for that. So let's crack on. So throughout this 15 minutes talk, I will mainly focus, this is my main references. You all can scan from the QR code to download the full guidelines. So it will be guidelines from the American Heart Association. This was just released this year in February. So it was a guideline in evaluation and management of acute pulmonary embolism in adults. Okay. So in the next 15 minutes, what we'll talk on will be on the, I will go through back a bit on the history of the patient, the critical care investigation, as well as the management and a bit of the discussion. So when the patient was decided on emergency cesarean section for abruptio placenta, she was brought into the maternity operating theatre. That was around almost midnight or 11 o'clock. Her GCS was not full, so he was E3, V4, M5. She was cyanosed, restless, mottled peripheries, CRT more than 2 seconds. So at this point of time, it pointing towards shock. Okay, so basically shock means that the blood pressure is low. That's why the patient is not fully conscious. The GCS is dropped, and she's cyanosed, mottled peripheries, and poor perfusion in the peripheries. Okay, we managed to get a good IV line, 18 gauge, and we pre-oxygenated her well, and induction medication for general anesthesia was given. For those who have done anesthesia, you noted here we are giving ketamine, okay, 50 milligrams, because the propofol that we're given actually will cause more on the depression of the blood pressure. So the ketamine will actually compensate for that. Okay, so the RSI, the rapid sequence induction, was done in this patient. So intubation was not an issue. It was quite straightforward using a video laryngoscope. Surgery started immediately after intubation. We managed to get an arterial line to measure the blood pressure of the hemodynamic of the patient, quite closely, beat to beat. And we also managed to get an external jugular vein using a 16 gauge needle, okay, inserted in the OT. This is actually to help us with the resuscitation. And then immediately after, the baby was out. But after the baby out, BP was still hypotensive and required intermittent boluses of vasopressor. Okay, with this intermittent boluses of vasopressor, we know that the BP cannot be sustained, so we actually decided to start on inotropic support. So we started on intravenous infusion of noradrenaline up to 0.2 mics per kilo per minute. Okay. Intraoperative, the BP was maintaining around 90 systolic to 128. And the heart rate was never below 110. So it's ranging around 113 to 150 beats per minute. So it shows that patient is actually tachycardic and in shock. Saturation was well maintained with the ventilator with a good FiO2. So these are the medications were given. It's the most interesting part here is actually the hemabate, because as mentioned by the ONG colleague just now, patient was actually, the uterine was atony, and we need to give hemabate for this patient to improve in the of the uterine contraction. Okay, so because of the hypotensive period, hypotensive episode of the patient that require inotropic support, we resuscitate the patient with the fluid. Initially was a crystalloid, total of 1.5 liter of crystalloid, and then we give a colloid with a gelafandine of 0.5 liters per minute. We also, because we didn't get the blood quite early on, so we only we managed to transfuse 2 safe O from the ONG department, from the OT, and then we transfused another 2 pint of PEC cells, so total pint of 4 PEC red blood cell. Because of the oozing and unable to secure the hemostasis, we decided to give blood products, which is a 1 cycle of a DIVC regime. So the blood products that was given is fresh frozen plasma 4 units, platelet 4 units, and cryoprecipitate 6 units. So the estimated blood loss at the point of time was 3 liters per minute. ABG was acidotic with pH of 7.2, bicarb of 15, base excess of minus 12.6, and lactate was 3.6, which is better from what she came with a lactate of 7. She's febrile, okay, and then we repeated the INR was the initial presentation, the INR was 5.64. PT was prolonged, APTT was also prolonged, okay. After resuscitation, it came down, but it's still on the higher side. The INR is prolonged 2.13 from 5.64. Fibrinogen was low. And because of this, we transferred this patient to ICU for further stabilization and weaning. So when the patient in ICU, the patient was ventilated with a low ventilator setting. We started on sedation with midazolam and fentanyl. The BP was maintaining with intravenous no adrenaline, but because of the hypotensive effect of we added on a second type of inotrope, which was vasopressin. So she was on 2 types of inotropic support. The ECG shows sinus tachycardia with a heart rate of 150 beats per minute. So it doesn't change that much from the operating theatre. And there was ST depression noted on the inferior 2-3 AVF as well as the lateral leads for V4 to V6. Okay, and the PETs was 1 PET soak. As I mentioned previously, these are the blood products that was given. And then we also sent for a D-dimer, and the D-dimer was raised at that point of time. So we're also thinking that why is this patient already resuscitated, still hypotensive and requiring second dose of inotropic support? So we decided to pull our ultrasound machine in the ICU and do a bedside echocardiogram. So this is actually an echocardiogram of our patient in the ICU. I apologize for the image, it's not so clear. Bear in mind that this is actually a maternity patient who actually has a thick chest wall and big pedunculous breast, and also she has a BMI of 30. Okay, so I just orientate you before I start the video. So basically, this is an echocardiogram. As labeled, RV is right ventricle, LV is the left ventricle, and RA right atrium and left atrium, and apex of the heart is on top here. Okay, so we'll see what was the well, this is the echocardiogram. So you can see the RV wall here is actually akinesia. It's not contracting that well. There's a paradoxical movement of the septum. And then the RV size is actually bigger than the LV size. And the hypercontractility of the apical of the heart. Okay, I'll show again slowly. The reason I didn't slow down the image, the video, is because I want you guys to see that the heart is actually contracting quite fast. Okay? The heart rate was about 130 to 150 beats per minute. So again, so the RV free was on this side. It's not contracting. You can't really see that well. Okay, I apologize for that. But you can see the paradoxical movement of the septum. So the RV size is bigger than the LV, and then the hypercontractility of the apical wall. Okay, so do you know what is the sign of it? Our fellow colleague of ONG has mentioned it previously. Okay, so the RV, basically, you know, the LV, the left ventricle, is the one who's actually more bigger, right? So the RV should be 1/3 of the size of the LV. But in this case, the RV is actually massive, it's big. Okay, that's why it's pushing the septum to the left side. Okay, So because of that, that's why the patient become hypotensive. So the blood cannot be ejected quite well from the LV to the circulation. That's why patient is hypotensive. The RV is very big, pushing the septum and impede the outflow of the left ventricle. So again, it's big, okay, it's a D-shaped RV. So this is called the McConnell sign, okay. It's a distinctive echo feature of massive PE. Okay, as I mentioned, the purple color is actually the kinetic of the mid free wall of the right ventricle, and the apex is actually hypercontractility to compensate for that. This McConnell sign is actually have a good clinical context, but basically you can only see it with the severe hemodynamically unstable patients. Okay, the overall specificity is not that good. It's only 64%. But if you see it, there's some pathological ongoing, then you actually have to proceed with more imaging. Okay, from here. So it's you couldn't really diagnose patient who has McConnell sign as a PE, but you need to further investigate this patient. Okay, so as I mentioned, it is not specific. It can increase. Patient who has acute increase in pulmonary vascular resistance will present with this. Patient who has chronic pulmonary hypertension also, and acute pulmonary embolism, okay, in this case, which is the most common etiology that you've seen, especially in an acute presentation, okay. So as I mentioned, echo is not a confirmatory diagnosis, okay. You cannot rule out pulmonary embolism in this case. You need to proceed with CTPE or VQ studies, unless the patient is hemodynamically unstable to transport the patient. So is McConnell sign the only parameters for PE? No. Okay, there are other things that you need to look at, such as the TAPC, the right ventricle end diastolic diameter. These are the parameters that a good sonographer or those who are trained in echocardiogram will look at and measures. So what happened then? The patient was sent to a CTPA that was arranged 4 o'clock in the morning. By the way, I need to thank my registrar who did really well for the echocardiography, the transthoracic echo. They are the one who pick up these findings in the ICU. So the CT was arranged after the positive McConnell sign, as mentioned earlier. So the results, as mentioned by the ONG colleague, is a saddle pulmonary thromboembolism with extension, involvement, bilateral pulmonary artery branches, features of the right heart strain. Okay. So the patient proceeded with a mechanical thrombectomy early next morning, okay, under general anesthesia, and it was successful. The patient was then sent to the ICU for weaning and extubated the next day and was discharged from ICU the following day. So at this point of time, I would like you to, for the discussion part, right? We need to know like this patient who are maternal patient came in with a hemodynamically unstable. Okay, so the three main things, the three main diagnoses, differential diagnosis should come in your mind, which is the pulmonary embolism. Okay, which is why? Because this patient who is pregnant, they are hypercoagulable. So based on the virtuous triad. Okay, and then the risk of amniotic fluid embolism is there, okay, although it's not so common, but you need to think at the back of your mind, especially when the patient presented with the IVC and cardiorespiratory collapse. The third one will be hypovolemic shock, okay. In this patient is actually a abruptio placenta with a DIVC as well. So DIVC in a late pregnancy, the two main things that you need to think about is amniotic fluid embolism and hypovolemic shock. Pulmonary embolism, not so much of the IVC, is more towards the hemodynamically unstable. The bottom two is actually not so common, but you have to think at the back of your mind. Maternal sepsis, especially when the patient doesn't have any good antenatal booking or follow-up. And the last one is actually myocardial infarction or peripartum cardiomyopathy. Okay. In this case, she has a raised cardiac enzyme, so that's why I put it here as our differential diagnosis. So I would like you all to think questions that we should ask ourselves based on this case. So the first question is, why does the patient experiencing abruptio placenta and DIVC still suffer thrombosis? Meaning that the patient is bleeding, at the same time there's a clot in the lung, right? It's quite weird. And then the second question is, does the pulmonary embolism occur before, together with, or after the abruptio placenta? Meaning that, does the patient has the pulmonary embolism when the patient has delivered the baby? Okay, when the patient was in ICU, when we actually corrected the coagulopathy by transferring the blood products and the IVC regime. Okay. Okay, let's go to question 2 first. It's much easier to answer. So when the patient, so we need to look back at the patient history itself. So she actually presented with shortness of breath, okay, and hypotension as well as a reduced GCS, reduced consciousness level. So the reduced GCS as well as the blood pressure, you know, is hypotension. You might think it because of the shock itself, okay, but to say that it's actually, but from the history itself, you know that the patient has shortness of breath. So it's actually more likely to pointing towards pulmonary embolism as well. So pulmonary embolism can be one of the, you know, the thing that happens during or before the abruptio placenta itself. Okay, if I say that the patient has a pulmonary embolism after the baby is out, okay, it's probably not correct. Okay, because when we corrected the when we corrected the coagulopathy using the IVC regime with the blood products, right? The INR, the coagulopathy did not correct it back to the normal range. Okay, it was initially 5, and then it came down to 2. So most likely the pulmonary embolism occurs during or before the abruptio itself. So going back to question 1, so why the bleeding and also the thrombus occurs together, right? So a useful way to think is about the IVC is actually the body is clotting so much that it runs out of ability to clot properly. So the clotting, so the, you know, the blood is actually using up a lot of clotting factors, but it doesn't clot that well. So the key concept of the IVC or DIC is not simply too little clotting. It actually means that a massive uncontrolled activation of the coagulation, followed by a consumption of clotting factors and also platelets that lead to widespread microthrombi, in this case, the lung, and severe bleeding tendency. Okay, so we're moving on to the management. So as I mentioned to my all fellow registrars, okay, in critical care, it's always safe to start with ABC, okay, airway, breathing, and circulation. In this case, patient after the cesarean section, we actually maintain, we keep the patient intubated because the patient was hemodynamically unstable, and we try to observe this patient in the ICU. We noted that the patient was hypotensive still. That's why we do further investigation by doing the echocardiography. So in terms of the circulation, patient was resuscitated with the fluid, okay, quite a lot of fluid. The blood loss was quite extensive, 3 liters intraoperatively. We give crystalloid, we give colloid, we give blood products, we give Paxil. So resuscitation was actually quite extensive and quite on par, okay, in this patient. And the inotropes was needed to actually help with the organ perfusion. Okay, so we want to make sure that the vital organs like the kidney, okay, the brain are actually perfused quite well. And the bedside echocardiogram is really useful tool for us to actually assess the fluid status as well as the cardiac output of the patient. Okay. Another thing that we have in the ICU is a cardiac output monitoring. Okay. I will show you at the end of the slide what the cardiac output monitor that we have in the ICU. The other thing is actually our central venous pressure. So the central venous pressure is like a catheter that we inserted through the intrajugular vein. It's not, we don't use it as a sole indicator to assess the fluid status, but with other combined monitoring, it's a useful tool. Okay. And then we mentioned that we repeated the DIVC screening to see the bleeding profile. And also there's some centers or institution, they will have this thromboelastogram or ROTEM, TEG. This will help with the patient who has massive bleeding, and they can decide on what type of blood product. So it's a targeted blood products based on the findings of the TEG. So moving on to the specific or definitive management. So we have our medical therapy who patient who has pulmonary embolism. Okay, so mainly are the unfractionated heparin as well as the low molecular heparin. We also have the patient who has a DVT, deep vein thrombosis. What you can do is actually we can insert an inferior vena cava filter. That will be later on in the management. The other advanced management that we have currently going to talk by Dr. Nick Farhan after this about catheter-directed embolectomy, thrombolysis, as well as mechanical thrombectomy. So if the patient is not stable, sometimes we can also offer a systemic thrombolysis, like a drugs that we give to thrombolyze the clot. Okay. So in terms of pulmonary embolism, okay, the initial classification or categories of severity of pulmonary embolism was, we were following all this while based on AHA. In 2011, so that was the criteria was massive, low, submassive, and massive. Okay, but as I mentioned earlier in the presentation, the one that you downloaded is actually the current guidelines, so which was published February this year. So we're now moving on to the 2026 guideline of AHA. But some centers can still, some centers are using the European, those who doesn't follow the American guideline will follow the European guidelines, okay, in 2019, where they classify into 4 classification: low risk, intermediate low risk, intermediate high risk, and also high risk. So this risk classification is based on the hemodynamic status of the patient, whether it's stable or unstable, and then the pulmonary embolism severity index, high or low, and also the evidence of RV dysfunction, meaning that there's an RV strain or not. Okay, so this is the AHA guidelines. So they have A, B, C, D, E. Okay, so A is actually subclinical, where actually there's an incidental finding. Okay, B is actually symptomatic patient with has a low risk, and C is actually symptomatic patient who has elevated risk. D is actually patient who has cardiopulmonary failure but is actually normotensive, and then E is actually in our patient is actually E, where they have the cardiopulmonary failure, where she presented with hypotensive and requiring inotropic support. So I'll show you again the same thing. So it's A, B, C, D, E, the classification based on 2026 February guidelines. So our patient is actually falls on this category E here, and it will be E has a subdivision of E1 and E2. So in this sense, the patient is actually falling in E1, okay, where they have a hypotensive and cardiogenic shock, whereas E2 is actually refractory cardiogenic shock or cardiac arrest. So she doesn't have any cardiac arrest, so she falls within E1 here. Okay, and then you can plus minus R here, meaning that there's a respiratory failure. So she's actually intubated, so she's actually with a E1R. So just sorry about the busy slide. So basically, this will tell us based on the so what's important about this category will actually determine us in terms of the management of the patient. So what's important is actually on the top below here. Okay, here. So you can see that the management here, so patient actually falls on the category E1. So the management is actually here, whether the patient will go systemic thrombolysis, in the sense that the patient cannot go systemic thrombolysis because she's actually post-operative. So the bleeding risk is high, and she also has a ruptured placenta. If you give systemic thrombolysis, the patient will bleed more, right? So the best way is actually to do a mechanical thrombectomy, okay? So CDL is actually mechanical thrombectomy, and MT is also a type of mechanical thrombectomy. So for my slide, these are the take-home messages. So maternal collapse is a medical and surgical emergency. It's a multidisciplinary team is actually key in better management of the patient outcome. POCUS or point of care ultrasound is useful, especially in critically ill hemodynamic assessment, because sometimes we cannot transport the patient to the scan. So bedside ultrasound scan is actually a very useful tool for us. McConnell sign has a good clinical context, but not a confirmatory diagnosis. CTPA and VQ studies are better sensitivity and specificity. Submassive and massive PE is no longer used in categorizing the pulmonary embolism based on the 2011 guideline. And advanced management of pulmonary embolism, okay, for category D and E, now is using the 2026 guideline. So with that, I thank you. So this is actually the hemodynamic monitoring that we have in our intensive care. Sometimes we use it in the operating theatre as well. This will tell us actually how good is the heart contract, how well is the vessels constricted or vasodilated. It will actually it will actually help us in managing the patient in terms of the fluid as well as the inotropic support. Thank you.
Okay, thank you, Dr. Nizam, for that very, very informative talk. And I would like to invite Dr. Nik Farhan, our interventional radiologist, to enlighten us further.
While we're waiting for the next speaker, I have a burning question. I've been asking my colleague right and left. Burning, first of all, before I ask the question, I would like to congratulate this very difficult case with tremendous outcome. You managed to save the mother and baby without HIE. Congratulations. Sorry lah, the next speaker ni bukan anti-climax Climax ni kat you kan. I nak tanya soalan ni. Okay. Let's say you identify the pulmonary embolism first. Kan? You identify first. Is there anything that you would do differently or you would still do the same thing like how you manage this patient? Siapa nak jawab lah?
I think we would do the same thing. Yeah, we stabilize the mother and then we deliver the baby because empty uterus can make the resuscitation process more easy.
Okay, thank you, Prof. Dekan, for the question. So basically what important in this case is actually, maybe if we go retrospectively, we look back, right, in the emergency department, the best way is actually, what we miss is actually, we should have just pull the ultrasound and, I'm not pointing, pointing fingers, it's just like, maybe we were so tied up with the, very unstable patient. I think the best way is actually, we just pull the ultrasound machine and just do a quick scan. Okay, maybe they did it at the ED, I'm not so sure, but basically maybe because the patient was very ill and we are really pushing the patients to deliver the baby quite fast. So maybe the best thing is actually we diagnose, maybe with that we can actually diagnose the patient with pulmonary embolism. But in terms of the management, I would say that we will not do it differently. We will still deliver the baby and we will proceed with the CTPA. It's just that probably the things that are going to be different is actually the time itself. Maybe we can, remove the clot for the pulmonary embolism quite early on rather than, 12 hours after delivering the baby.
Okay, shall I start? Assalamualaikum, very good morning to all distinguished speakers and guests and all of the audience members, especially all the medical students. Okay, first of all, what imaging modality that would you suggest in the case of PE? Okay, then that's one goal achieved. Should you do X-ray? But X-ray is part of the screening or first line imaging, right? In any emergency. Yeah. But yes, CTPA is the modality of choice. CTPA is the gold standard and it should be used, and because it has very high specificity and sensitivity to detect pulmonary embolism. But what is beyond pulmonary embolism that we should be detected on CTPA? It's been described by our previous speaker, Dr. Nizam. Okay, we are not looking just for clot in the pulmonary artery. We are looking also for something like McConnell sign, but in CTPA. So those kind of findings that we are also looking at in CTPA. All right. So we are looking for increased right ventricular to left ventricular ratio, which is considered abnormal. More than one is already considered abnormal. Echo is also an imaging modality that has also sensitivity to detect, specificity to detect RV-LV ratio. In the cases of patient with what do you call that, contraindication or of to do CT or CT unavailable, VQ scan is an option, but it is rather less practical compared to CTPA. VQ scan is a nuclear medicine study. It is not available 24/7 and it takes a long time compared to CTPA, which can give a rapid result. In the cases of absent of those modalities, let's say we are in maybe smaller medical centers, smaller clinics. In the cases of you suspected a PE, but you have only ultrasound, what you can do is also do ultrasound of the lower limbs to check for clot in the femoral veins or popliteal vein. And with the clinical signs and history suggestive of PE, you may already start to warn yourself and to treat this patient as PE before reference to other centers. All right, so as I mentioned, CTPA, not only to look for clot, Can you see the clot in this CT? This is not this patient CT, a different patient. All right, I think it's quite clear. Okay, those are the clots in these pulmonary arteries. But what are other findings that we can see here? Increase RV to LV ratio. And also, we can also see another sign is larger pulmonary trunk compared to aorta. But I will show the images of this patient later. Okay, this is the finding that we also want to see. As I mentioned, RV should be smaller than LV. And this is abnormal. This is abnormal appearance in PE, where RV is larger than LV. And also, if you trace the yellow dotted lines, those are the interventricular septum. It should be, in a normal situation, it should be bowing towards the right ventricle, but it is flattened in the cases of PE. Another sign is contrast reflux into IVC. This is the IVC in a normal CT, but when the contrast reflux into the IVC, this is a sign that there is an obstruction in the pulmonary artery. So what is the importance of these two findings? I mean, we are looking for right ventricular strain. So right ventricular strain is, this is a death spiral of PE. Increased right ventricular afterload causes right ventricle dilatation, tricuspid valve insufficiency, and all of these lead to myocardial inflammation, and then right ventricle ischemia, hypoxia, which reduces the right ventricular contractility output, the LV preload, reduce cardiac output, and reduce systemic BP. And then coronary perfusion of the right ventricle will be reduced, and there will be reduced oxygen delivery to the right ventricle that leads to obstructive shock and death. This is the CT of this patient. It's quite a fast scroll, but if you can see here, okay, so there is a saddle embolism. I will trace it later here. And then we can also see the right ventricle larger than left ventricle. The pulmonary trunk is also larger than the aorta. So those are positive findings. Again, pulmonary trunk ratio to the aorta is larger in this patient. Okay, that is the clot sitting on the pulmonary trunk division like a saddle sitting on a horse. So that's why we call it saddle embolism. The extension of the clot towards the right and left ventricle, if you can see the red dotted lines. So this is an extensive clot into the bilateral pulmonary arteries. And then right ventricle larger than left ventricle, again with flattening of the IVC, interventricular septum. Again, saddle embolism in coronal view, resembling a saddle on a horse. Okay, next. So, Dr. Nizam from previous speaker has explained about 2026 AHA guideline, but I would also like to include European guideline published in 2019. I think, in my personal opinion, it is quite clearer for us to, for me to guide for in terms of treatment. Okay, so they divide the groups into color codes. Okay, red, yellow. In yellow, there's orange and yellow, and green, low. So red is high risk. Next is intermediate high, and intermediate low, and there is low risk. So the difference is high risk has hemodynamic instability, clinical parameters of PE severity, RV dysfunction, like we have seen in the CTPA, and then elevated troponin. Whereas in intermediate high, there is no hemodynamic instability, but it ticks all other boxes. Intermediate low, the patient is stable, but there is PE severity, but either one only is positive between right ventricular dysfunction and troponin. And then for the low risk is negative for all the categories. So from this guideline of treatment, Okay, patient with acute PE. First step is anticoagulate. If the patient is contraindicated to anticoagulate, then it's a different story altogether. So does the patient has hemodynamic instability? If yes, the patient goes to the high risk, and in the red color code, the reperfusion is suggested. So reperfusion therapy is either catheter-directed thrombolysis, surgical embolectomy, or thrombectomy. And if the patient is orange code, it is also suggested for reperfusion. I will walk you through this. And then for color yellow code is hospitalized. And in Europe, those with positive PE but ticks not tick on other boxes, then they will treat at home, early discharge or home treatment. Okay, but I think it's probably not yet practiced in Malaysia. So number one, hemodynamic instability based on certain criteria, whether there is cardiac arrest, obstructive shock, or persistent hypotension. And then next, we look at clinical signs of PE severity. So this is a calculator that used for PESI. What do you think the score for this patient is? Age less than 80? Yes, less than 80, 0. History of cancer? None. History of chronic cardiopulmonary disease? No. Heart rate? Is it more than 110? Yes. And then systolic BP? Was it less than 100 or more than 100? There is an instance that it was less than 100, but oxygen was always maintained 99%, I think. So this is the score for this patient. So score of at least 1 and above is already a high risk. Does this patient has RV dysfunction on CTPA? Yes. All right. Okay, so let us walk through again. Is the patient hemodynamically unstable? Yes. So straight answer, high risk, go to red, and mechanical thrombectomy or catheter-directed thrombolysis is there is a role. Let's say the patient is stable. Okay, we go to level 1 and we check 1 and 2. Does the patient score more than 1 on PE, SPC, or any RV dysfunction? If 1 or 2 present, perform troponin test. If troponin test is positive, it goes to orange. Also go for treatment, mechanical thrombectomy or lysis. So that's why currently we are always asking for troponin level. I mean, when we were referred for mechanical thrombectomy, one of the questions is, what is the troponin? Okay, rather than D-dimer. So D-dimer maybe 10 years ago it was a tool, but now troponin, because it is a marker of cardiac injury. So it tells us that right ventricle is damaged. Then if the patient has none of this, if the patient has only one of these positive, the patient goes to yellow, still hospitalized. But if shows clinical worsening, then reperfusion therapy is also suggested. So that's why the yellow color is still considered within the same box of the orange and red. All right, so this is just a walkthrough between AHA versus ESC. Yes, 7 years apart difference, but I think 2019 ESC guideline is still applicable, and we can harmonize it, okay, based on the categories that it has both guidelines has mentioned. Not much difference actually in terms of treatment. Still, they agree on treatment for mechanical thrombectomy or catheter-directed lysis in the high risk and intermediate high risk. All right, I think I'll move on to this. Okay, so we have checked that this patient is unstable and positive on PSPESI, has RV dysfunction and elevated troponin. Okay, so the patient can be suggested for thrombectomy. Okay, I skipped a few slides because of I think a lot of overlaps. So options of thrombectomy. We can do large bore aspiration catheter. So this is the clot in the pulmonary artery. A large bore is inserted, and then aspiration using this vacuum syringe, 60 ml. And then this syringe with blood and clot can be filtered through this filter so that the clean blood can be returned to the patient. So every time aspiration done 60 ml, there will be clot and blood. So the clot will be separated by the filter, and then the filtered blood will be returned to the patient immediately. So in other words, this minimizes the blood clot. This is the system that we used in this patient. Another system is using computer-assisted vacuum technology. So the computer-assisted aspiration will detect aspiration of clot and stops when it aspirates blood. So it only aspirates clot. When it aspirates blood, fast flow, so it stops, and we will adjust our catheter. So again, the same thing, wire in to the pulmonary artery, and a large catheter goes up, a machine is attached, and then red flow or green flow when it is aspirating against clot or blood. So all in all, both systems want to minimize blood loss. And then another system that can be used, and we've used before, is a catheter-directed thrombolysis, but using ultrasound assistance. So ultrasound, this catheter will be put into the pulmonary artery, and then RTPA can be infused, or any lytic can be infused, together with ultrasound vibration by the catheter. So ultrasound vibration will cause more delivery of the medication against the surface area of the clot. Okay, so for this patient, first of all, we punctured the right femoral vein, and then we put up the wire with catheter, and then this is a large bore catheter, 24 French, and then the wire will go to the right, to the pulmonary right ventricle, and then pulmonary trunk, and then into the right pulmonary artery now. So we put the catheter up, and then this is the run that we did. So can you see the filling defect? Okay, this is the filling defect part of it, because we are now in the right pulmonary artery. And then from now on, we did the aspiration. And then we move on to the left pulmonary artery. Some filling defects are seen, and aspiration is again done. And this is the final angiogram. So it shows perfusion of bilateral lungs, and with the clots removed. Okay, so this is probably one of the simplest PE thrombectomy that we did, because I think the first or second aspiration we got the whole strand all together, and it is connected. These are all connected, so resembling the sendal embolism that we got it. So we were lucky that this was the result, and I think post thrombectomy the patient improved so much afterwards. Yeah. I would like to end again with a reminder of suggested guideline by European for the treatment algorithm. We can harmonize it with the AHA American guideline. And this is an idea of, sorry, baru nak cakap idea. Okay, so this is an idea that is being proposed throughout the world of having a PE response team in the hospital, where it combines different modalities, different specialties that can sit together and can discuss on management of patient. Those with low risk can be clearly managed. Those with intermediate risk, whether it's high or low, when should we do reperfusion, any role of revision of risk also can be done. Yep. So with that, I end my presentation.
Thank you, Dr. Nick Farhan, for that very informative talk and very interesting slides as well. And let us welcome Dr. Rowaidah, our last speaker for today, our obstetrician and gynecologist from ONG department.
Okay, thank you, Prof, and everyone that come. Let's stay until the end. Okay, I will talk about 10 to 15 minutes. Okay, this is a theory part of it, a summary of the case. So I'm Dr. Rowaidah, ONG specialist in HCTM. So today I want to talk about something that's every obstetrician worries about. Okay, a pregnant mother who suddenly become critically unwell right in front of you, and you have a minutes, not hours, to decide what you want to do. Okay, let's ground ourselves on these numbers. Okay, because these aren't just a statistic. Every figures represent a mother who did not go home to their families. Okay, so in 2025, 17.8 of maternal death were linked actually to because of cardiac disease. Nearly 1 in 5 mothers. Okay, but when we look at the maternal mortality ratio over time, during the pandemic, the higher MMR led to 68.2, which 18.8% were caused by obstetric embolism, which reflect a full force of COVID-19 on pregnant women. 2023 to 2024, post-pandemic stabilization, however, our MMR was plateaued to 25 to 26, suggesting that we had not returned back to our pre-pandemic level. Okay, so we go to our obstetric embolism. In UK, 1.56 per 100,000 maternal death die because of pulmonary embolism. This is a very small number compared to Malaysia, but every single one is preventable. Massive pulmonary embolism kill very fast. 50% die within 30 minutes, 70% die within an hour, and 85% die within 6 hours. Bleeding risk in patient with postpartum thrombolysis, okay, carries a 58.3% bleeding risk compared to antenatal when we give a thromboprophylaxis, 70.5%. Perimortem cesarean section, if the mother arrested, you begin at 4 minutes and deliver the baby by 5 minutes, okay? Not for the baby alone, but because the empty uterus gives the mother her best chance for return to spontaneous circulation. And when thrombolysis is given in pregnancy, maternal survival rate increased to 94% and fetal survival increased to 88%. When the medication is indicated, it will work. Okay. All right. So we move on to the discussion. When a mother deteriorating unexpectedly and silently, the clinician at her bedside must be always ready. Okay, this is what is our job. So we only have one job, to act fast and to act smart. Okay, 5 steps that guide you to manage a maternal collapse. Early recognition. Something is wrong, say it out loud. Okay, do not wait to be certain. And then call for help, activate your emergency system, red alert, call up your senior, your multidisciplinary team, and then ABCDE resuscitation, airway breathing, circulation, disability and exposure, basic life-saving skills, all right? And then find the reversible causes. There is where you need to think. There were 5 major causes, all right? And rapid MDT escalation, involve all the units in your hospital, get everyone ready, moving at the same time, and then proceed with continuous monitoring, treat the causes, prevent all the complication, and communicate clearly with the family members. Okay, 5 causes that you must always think and must know. If the first one is massive hemorrhage, the major cause can be placenta abruption, bleeding placenta previa, uterine rupture. The second one is thromboembolism. Okay, and then the third one is hypertensive emergency, such as our severe preeclampsia and eclampsia. Fourth one, sepsis. Bear in mind chorioamnitis, pneumonia, pyelonephritis, and the fifth one is cardiac causes, peripartum cardiomyopathy, and arrhythmia. Okay, what happened to the mother and the fetus when the mother collapsed? So Dr. Nizam already explained the pathophysiology of how can abruption, which one come first, abruption or pulmonary embolism. It all begins with the Virchow's triad when the venous stasis come because of the iodocaval compression, endothelial injury from the inflammation, and hypercoagulative state during pregnancy. These all together form a deep vein thrombosis that might be dislodged and travel to the lung, okay, as a pulmonary embolism. This massive embolus cause acute pulmonary hypertension, cause right heart failure, leading to systemic hypotension and also shock. And then the maternal shock leading to acute reduction in the uteroplacenta perfusion and placenta separation. This performed hypoxia cause placenta ischemia and also tissue injury, weaken the placenta attachment to the uterine wall, and also the release of catecholamines lead further intense the uterine vasoconstriction, further reduce the placenta blood flow, and also triggering the abruption. Okay, this is what happened to the babies. Okay, the severe placenta abruption caused sudden maternal bleeding and loss of placenta blood flow, leading to acute fetal oxygen deprivation. If you delayed, ongoing hypoxia triggers the widespread brain injury to the fetus, swelling, inflammation, irreversible neuron damage that can result to hypoxic ischemic encephalopathy, causing permanent brain damage, cerebral palsy, developmental delay, organ failure, and death. Okay, every minute matters. Okay, how we manage the critically unwell pregnant patient? What is our dilemma as an obstetrician? So when we have 4 major dilemmas, okay, that require fast decision making. Number 1, do we proceed with deliver or we stabilize the patient first? So the key action is you assess the maternal stability first. Okay, assess the fetal status, discuss with all the team, and decide either you want to immediately deliver the babies or stabilize first. Okay, number 2, in pregnant mother who is thromboembolic state, managing the active hemorrhagic while balancing the anticoagulation is extremely challenging. Okay, we must weigh the risk of clot against the risk of further bleeding. So the key action is to identify the cause of bleeding. Is it a rupture? So you must stop the bleeding by correct the clotting factor. Number 3 is the surgery. Can we safely take this patient to operating theatre and do a cesarean section, or with underlying coagulopathy? The surgery is safe. Okay, so this is important key factor. You check with your labs the platelet count, the INR, the APT, the fibrinogen level. Treat all the coagulopathy prior to the surgery or during the surgery. Control the bleeding with good surgical skills, and then give all the uterotonic agent that you have, balloon all the mechanical compression, and go in when all the teams are ready. Oh, sorry. Number 4 is maternal rescue or fetal well-being. So every decision must carefully consider the impact on the fetus. Okay. All right. So the role of MDT. Okay. Like Dr. Nick Farhan said, in a neighboring country like Singapore, actually they have a pulmonary embolism response team. So any area if you have a embolism, massive embolism in Singapore, you have less than 1 hour to activate the system. So I go to the Singapore last year, they have a very good team. When the emergency system was alerted, 30 minutes, the team already come to the hospital to attend to you. Okay. Right, this is the team that involved in this case. Okay, we have almost 8 team involved. Okay, almost half of the hospital is managing this one case. Okay, this is what happened to the patient. Massive hemorrhage because of placenta abruption. Okay, lead to uterine atony and also convoluted uterus. This is in severe abruption like this patient, the blood infiltrate deeply into the uterine muscle, causing the uterus become bruises, swollen, and unable to contract effectively. This failure of contraction lead to massive bleeding after delivery. Okay, sometimes we able to secure the bleeding with only a compression suture. Sometimes hysterectomy are required to save the mother life. This is a patient. This is not AI generated picture. This is a picture that provided by the patient. This is the patient. The picture was took last Raya. Okay, so the babies is a very healthy and happy. Okay, right. Managing a postpartum. Okay. Okay, so managing a postpartum patient who survived massive pulmonary embolism complicated by massive PPH with a baby with HIE required a highly coordinated multidisciplinary team. Okay, so when patient was discharged from the hospital, leaving the hospital doesn't mean that the danger is over. Okay, for high-risk mother, what happened after discharge can be just critical as what happened inside the ward. Thus, we have a high-risk postpartum discharge protocol. Okay, so in Malaysia, we will call up the nearest klinik kesihatan to the patient house. We ask them to do a home visit daily, 7 to 14 days. They have this system from this Malaysia perinatal care protocol. They will come to the patient house every day to look for the vital sign monitoring, and to make sure the patient adhered to the medication, especially this patient on direct oral anticoagulant therapy. And for the cesarean wound care and any red flag, they will bring back the patient to the hospital immediately. Okay, this is after acute emergency stabilization, the focus shift to the preventing further blood clots. So most of the patient after massive PE require 3 to 6 month anticoagulant therapy. This patient fortunately was given DOAC, is a direct oral anticoagulant therapy, which is rivaroxaban. Is considered compatible with breastfeeding. It's a very low level, transferred to breastfeeding. So patient was on this treatment for 3 months, and the repeated echo after 3 months there is a no more right heart failure. So she was then off with the treatment. So what the next important things is contraception planning. So the safe contraception after thromboembolism is avoid estrogen containing contraception, because due to high risk of recurrent clots. So the safest and most effective contraceptive method is either your Mirena or your Cooper IUD. Okay. This patient was inserted with Cooper IUD in private GP. Unfortunately, the IUCD was dislodged. Okay. After a mother survived from the pulmonary embolism or thrombosis in pregnancy, identifying the cause is essential to reduce the future risk. Okay, thrombophilia screening is important in women with massive PE or any history of recurrent pregnancy loss or any history of thrombosis in the young age. Antiphospholipid syndrome also very important because it causes both thrombosis and serious obstetric complications, such as in this patient, she had a placenta abruption. So the final slide is highlight the future pregnancy counseling. This patient needs a pre-pregnancy counseling before embarking to the new future pregnancy. Okay. So patient education also important. The education must include how to recognize the symptom of thrombosis, the warning sign, to emphasize on anticoagulant compliance, the contraception planning, and the follow-up schedule. For this patient, we seen her back in 2 weeks in our clinic, 6 weeks postpartum in our contraception clinic, 3 months, 6 months, 12 months to see the outcome of the mother and also the baby. So the learning point, this case reminds us that managing thrombosis in pregnancy is extremely challenging. Okay, when bleeding and coagulopathy occur together. Careful anticoagulation sequencing, thrombophilia workup, a long-term follow-up is very essential. Most importantly, early recognition and fast action can save both mother and baby life. Okay, this is the babies. Okay, currently already 5 months old. Okay, the development milestone is correspond to the age. Okay. With that, I thank you. All right. With the team, every minute's matter, every discipline matter.
Thank you so much, Dr. Rowaidah. In the interest of time, I'm not allowing any questions at the moment, but rest assured that You are all welcome to ask questions after this to all the distinguished speakers, or you can always, email them as well. And with that, I would like to close the session, and I would like to thank all the speakers for that very, very informative lectures. I think everybody in the audience agree that we all are like 2-3 times cleverer today. So after this, we know how to manage, and we understand, thrombosis, thrombectomy, and all this better. I feel like I'm 25% better in, imaging and whatnot. Thank you so much, and thank you to all the audience today, and thank you to Prof. Datuk Marina for spending your time with us today.